A case is about 61 years old, non-diabetic hypertensive with severe reduced ejection fraction 20 to 25, non-ischemic cardiomyopathy, BCI to LAD and RCA, and BTCA to diagonal 1, non-AFib and rivaroxaban with a normal kidney function admitted through the ED with a decompensated heart failure. This is the patient initial chest X-ray at the ER admission. As you can see, there's extensive pulmonary edema that required a couple of days to optimize the patient. His investigation showed an echo ejection fraction of 20 to 25, RV normal in size. There are two clefts, posterior mitral leaflet MR, that is originating mainly from the medial cleft at the B3 and A3, with small jet from the lateral cleft also. There is a severe MR with systolic pulmonary vein flow reversal, with a pulmonary artery systolic pressure of 45. His diagnostic coronary angio was done, left main average in size. There was no disease, patent stent in the LAD, mild disease in the circ, and patent stent also in the RCA. This was his echo. Dr. Anas can help us with this.
Can you comment, Anas, please?
Yeah, so on the first image on the left, so that would be your bicommissural view. On the right side of the screen would be the lateral segments of the valve, where you see the appendage. And on the left side of the screen is your medial side, and you can see that there is a significant, fairly localized, medial jet that we see there. Just looking at the long axis view as well. So the far right side image, this is your anterior posterior plane. Again, we can confirm that we have significant mitral regurgitation. Just an important point to talk about here. I know that there's no, I think there's no 2D images here, but the differential diagnosis, when we see a fairly localized jet on the medial side of the valve, and there, we have the appearance in the other images that may look like a cleft, there's kind of three differential diagnoses that I would think about. Number one is sometimes with heart failure and reduced ejection fraction, you get extreme tethering of the leaflets, and especially that posterior leaflet, and especially on the medial side of that posterior leaflet. So you get what looks like a dropout between the P2 and the P3 segments, which may appear like a indentation or a cleft. The other two possibilities, obviously, if we see that dropout is an indentation, which we more commonly see outside the setting of functional MR, more like myxomatous, disease. And then finally, a true congenital cleft, which is not very common. So these are the things that would go through my mind when I look through this case.
Next picture, Meshari.
Yeah, so these are 3D images of the valve, and we can again see on the 2D images that between the P2 and the P3 segment, you do see you have a sense that there is a more apical tethering. You see like it's more darker, so it means that the tissues are away towards the kind of LV apex. Again, the overall picture here is more consistent with, I would say it's extreme tethering of the posterior leaflet, giving us that appearance rather than a true indentation or a cleft, but I would confirm with other images.
Next. So I'm assuming, Meshari, that the patient came with pulmonary edema. He was optimized with medical therapy, diuresed, and maybe some sort of nootropic support shortly in the CCU. Then when he was in euvolemic status, the patient had his, investigation, including coronaries and the TEE. So now we have an ischemic cardiomyopathy in a 61 or 60 years old gentleman who has no patent stent and reduced ejection fraction of 25 with a severe MR, who brought him with heart failure. So we brought this patient now to the heart team discussion. What is your thought, Dr. Raed? I mean, is there a rule for surgery, either robotic for him, or should we say, percutaneous or medical management or advanced therapy?
I mean, there's always a rule for surgery, but I think in this case, I prefer, if I'm not gonna, he has a stent or patent, he's at high risk. First of all, I think I will have the heart team and LVAD team evaluate him. But for this, I think I will go for TEER. I know there is restricted posterior leaflet, but I think it's probably clippable valve.
What about you, Ali? I mean, surgeons are saying this is too much risk, should be evaluated by, the advanced heart team, consider TEER. And I know you have some experience with transcatheter mitral valve replacement rather than repair. Is there any room in this case?
So I agree with all the comments here. I think this is even a very high-risk procedure for a percutaneous option. And one of the things that really scare me when I see severe mitral regurgitation and severely decreased LV systolic function. So here the ejection fraction is 20%. It's probably lower than 20% because of the severe MR. So I think TEER is well established. The beauty about transcatheter edge-to-edge repair, it's safety. So it's a very safe procedure to do. And the anatomy seems to be feasible for a mitral clip. So I think considering a mitral clip is not unreasonable. There's that paradigm of whether after fixing the mitral valve, will the patient actually benefit or get worse because of the severe LV dysfunction. That's sometimes very hard to predict. But I agree with Dr. Raed. This is a young guy. He would be a transplant candidate in terms of age cutoff. Probably starting with a transcatheter edge-to-edge repair and then reassessing the need for transplant would be my way to go.
Dr. Nicole, what is the guidelines tell us? The European guidelines,
Yeah,
specifically.
the European guidelines will give us a class 1 indication for edge-to-edge repair, and regardless of the risk of the surgical risk, we are dealing with a secondary MR. But one thing that is in the guideline and that we don't have here is what about the medical treatment? So the guidelines are class 1 in case we are at the optimal achievable medical treatment. So I suppose the patient is already stabilized and treated, but I mean, it's a class 1 indication.
So class 1. What about Dr. Muhammad? Any room for mechanical support during this case? We saw the chest X-ray was horrible. He had a short period of support in the CCU. Will you do this TEER, presumptively, with the support of an Impella or an intra-aortic balloon pump, just to help with the induction, or it depends?
I guess it depends. If the patient was on support, I will do the clip on support. If he's not, then I will try to do the clip without support, but we will have the backup, and balloon pump usually works very well in those cases. Impella, it can be, I mean, you can use Impella, but I think balloon pump usually is enough for those cases.
Dr. Anas, any experience with having a support while doing TEE intraoperatively? Will it mess up your results or mess up your interpretation?
Yeah, so we do have experience with that. So there's these patients with very advanced heart failure, very dilated LVs, very poor EF, where we have around 10 cases where we've preemptively started with a balloon pump, and just to kind of support the procedure, because we didn't know how they would react to the reduction in MR, whether there would be an afterload mismatch. And I think in most cases, the clip, the cases went as usual, with edge-to-edge repair. The only point is you have an artificial kind of sort of reduction in MR when the balloon pump is on. So before you actually start the case, you need to pause the balloon pump, do your baseline screening, and then with the edge-to-edge repair, once you implant the clip, before you actually release it, you need to pause the balloon pump again to look at the MR to make sure that you've actually had an effective reduction, because that balloon pump always kind of results in a reduction in MR. And I think that's quite important. And whether it's actually beneficial to use a balloon pump specifically for the mitral valve edge-to-edge repair, I'm not sure we have good evidence for that. We know that it's safe because we do have our own anecdotal experience with that. But I'm not sure how much it did help, and whether the evidence actually supports it. We don't have that yet. Yeah.
Okay, so we have around the table consensus going for a percutaneous TEER in this case, without standby if we needed a support, and if it's going to be an intra-aortic balloon pump. So what happened after that, Meshari?
I think
So-
And what does the data say? So you can take a seat, Dr. Meshari, please. So this is what we were talking. This is the heart team. But does the data support what we're saying? Dr. Muhammad is going to give us a brief about it.
I hope so. All right. So my disclosures, I don't have any disclosure related to this talk. So what does the data say? I think we cannot ignore the COAP trial when it comes to data. The COAP trial is a major trial that looked at the role of MitraClip in patients with severe heart failure on goal-directed medical therapy, and they are still symptomatic. As you can see from this slide, it reduced mortality and reduced heart failure hospitalization by around 18%. We are talking about absolute risk reduction in this trial at 5 years. And when we look at mortality, we can see that there's a 10% absolute risk reduction as well. So there is a very strong evidence for the use of MitraClip in advanced heart failure in patients with goal-directed medical therapy. There is a nice registry as well from Euro, the SMR, secondary MR registry, that looked at the role of MitraClip for also the ease of up-titration of medical therapy. Around 40% of patients where the physicians were able to up-titrate their medications, and that includes the ACE, the beta blocker, and the MRA. So how does that translate to outcomes? The patients who had up-titration of goal-directed medical therapy, they had reduced mortality, and so up-titration medical therapy was also associated with reduction in mortality or heart failure hospitalization. And that actually led to, and mainly because of the COAP trial, to give M-tier, a class 1 recommendation for therapy in patients with severe MR or ARO of 0.3. So we need to know that the ARO is 0.3. You don't need to wait for it to be 0.4 to intervene. Okay, and patients who have COAP-like criteria in terms of LV function and RV function. And it gave class 2B recommendation for M-tier in patients with advanced heart failure for symptoms or bridge to LVAD or heart transplant. So it's also in patients who don't have COAP-like criteria or on the transplant list, there's a class 2B indication. Do we have data for that? Yes, we do. And that's come from the MITRA Bridge Registry. We have 1-year outcome data in that registry. So enrolled around 120 patients who were either in the transplant list, around 30% of them were in the transplant list, either were offered CLIP for bridge to decision or bridge to candidacy. So they were not candidate due to social factors or medical factors, and they want to know if they will be candidate. So what did the study show? It showed that the MitraClip or M-tier is actually feasible and it's very safe, and survival was about 100% at 30 days. The success was close to 90% in reducing MR to less than grade 2, and the freedom from heart failure hospitalization, need for LVAD, urgent transplant, or mortality was about 64%. More than that, about 25%, or 23.5 to be very specific, were actually no longer needed heart transplant in the registry. We also have data in the use of M-tier in cardiogenic shock, and the data comes from our American colleagues and from the SDS TVT registry, enrolling around 3,800 patients. Device success was also acceptable. About 86% of them had MR reduction in less than grade 2 without any complications. There were some device failures, but at 1 year, the 1-year outcome showed that patients who had MR reduction actually had reduction in mortality and heart failure hospitalization, and these are the number needed to treat, so we are talking about 4 and 6. So just to put things together, so LVAD versus MitraClip in our patient. So MitraClip, yes, we do have data for M-tier to be more general. that it reduces heart failure and mortality. We know that LVAD also works very well, and we have a 5-year survival data up to 60+% in those patients. But LVAD, you know, a little bit more invasive compared to MTR therapy. So why we don't up-titrate the therapies that we are giving the patient with MTR first, with medication, then MTR, and then consider LVAD. As you know, LVAD can be associated with bleeding, stroke, and infection as well. So just to put things together for our patients, so MTR is less invasive. It has class 1 recommendation for our patient because our patient has COAPT-like criteria, and it still preserves LVAD and heart transplant options. About 30% of the patients who were in the mitral bridge registry either underwent heart transplant or LVAD without any issues. All right, I think that's it.
Thank you,
Maybe
Dr. Mohammed. We will,
So we can transition to Meshari right now, and he will tell us exactly what happened to our patient.
so tell us what happened, Meshari, in this case.
So we decided to proceed with MV-clip, and this is a procedure transesophageal echo.
So I will let Dr. Anas here comment along with me. So Dr. Anas, you can take it from here.
All right, so mitral clip starts with transeptal puncture, and what we typically puncture at is slightly posterior. So anything closer to the aortic valve here is anterior. So we go to the kind of this is a bit a posterior puncture, which is appropriate and slightly inferior, so that we puncture above the coaptation line of the mitral valve. So that's where the procedure starts.
Next.
Yeah. Once the guide catheter is advanced and the clip delivery system is introduced through the guide catheter, we advance the whole system down above the valve, and we check for trajectory, rotation, grippers. So you can see that the clip here is positioned above the mitral valve. Slightly here, I see it at A2, P2, but it would be eventually repositioned closer to the actual defect, yeah, to the leak.
Next.
We can see the team here chose to clip. I know that I think eventually they have implanted
There's a
overall.
second clip, yeah.
Yeah, there's a second
You
clip,
can see
so
that
the first clip.
blocking here is a
Yeah.
bit like, you know, from 12:30 to
Yeah.
6:30. Next. So this is, I think, the second one. Next.
Yeah.
So we can see like the bicommissural view and explaining and having a good grasp and
Yeah.
making sure that the leaflet within the apex. Next. Next. So this is the second one, I think. Next.
Yeah.
The gradient. So what else, like, you know, apparently from their strategy was to have like an A figurine to, you know, sandwich the cleft between both of them. Most likely they used the short arm. It looks like an Abbott NT, both of them going this ways or NTWs. And their gradient is a bit 3 at a heart rate of 75. What other parameters are going to be, you know, beside the MR reduction,
Yeah.
the
so
gradient?
I
Any
thi-
other things that you have to tell me during the case?
Yeah, so in addition to the gradient, in addition to the residual leak, what I usually look for is the pulmonary vein. And I find, just from my experience, that the patients who have improvement in their systolic, you know, they have more forward systolic flow in the pulmonary veins, tend to have the most symptomatic, you know, improvement after edge-to-edge repair. Some people also look at the stroke volume, you know, before and after, but, you know, the main things are gradient, leak, and the pulmonary veins. It's very important that if a patient is on inotropic support or if they're tachycardic, just be a bit mindful that you could be overestimating their gradient. So make sure the heart rate is controlled. If they're on inotropes and they're tachycardic, maybe just slow that down a little bit and reassess the gradient. And just also be mindful that when they wake up the next day, the gradient would be, you know, 2 to 3 points higher than what you see in the cath lab. Yeah.
Dr. Ali, also you've been doing these cases. Any other parameters that you have to keep in mind? Number one. Number two, leave no MR behind. Is it still like, a concept, considering the fact that this is a ventricular reduced ejection fraction? Because there at one point discussion about leave a bit of MR, the LV will not tolerate. Any thoughts about that?
So those are great questions in this, and I just want to echo Anna's comments about the heart rate. As you can see here, the heart rate is 94, and the gradient is only 3. So I think that's an important observation. Now, the better the reduction of MR, I think the better in terms of clinical outcomes. I think with TIER, we've seen data to suggest that even if you go from severe to mild, patients benefit a lot in terms of reduction of hospitalizations and potentially mortality. So I would be happy with a mild or trace MR in that case for sure.
Okay. Next, Meshari. So, Dr. Nicole, do you accept these results, or are you going to add more clips?
No, I guess the results are excellent. We don't need to add anything. One only thing, and again, is the medical treatment as shown in the paper from Mariana. What we need is to optimize medical treatment afterwards, but this is an excellent result.
Okay. So any rule, like, for NS, to check the LVOT, VTI, to estimate the stroke volume or the cardiac output? Or you have...
Just to confess, I don't do it routinely, but sometimes I do look at the stroke volume, before and after, and just to see, out of interest if there's any improvement. But I find that it doesn't really change what I do. But with effective reduction in MR, I most of the time I do find some improvement in the calculated stroke volume.
Okay. Next, Meshari. So we can see here, as we said, there is a configuration of an A in the A2P2 and one in the middle, and we have a good MR reduction. Next. So this is the transthoracic next day. So Ali, now, Mohammed, sorry. You see this transthoracic the next day, and the patient now on 60 or 40 Lasix, TID, BD, and the 4 pillar of heart failure. When are you gonna start to turn it down or turn it up? What is your pharmacological management after this, with these results?
Yeah, again, as shown in the European registry, I think we should take advantage of the MTIR therapy to up-titrate the medication as much as we can, and I would do it the next or within 48 hours of up-titration of medication as much as we can. Yeah.
Okay. What about NS? Any follow-up with echo after this next day?
Yeah.
Thoracic?
Yeah, just
what do you recommend?
Yes, exactly. So we do a next day transthoracic, and then at 1 year, and then annual thereafter. And what we look for in the initial transthoracic is to make sure that the clips are well seated. There's no evidence of excessive mobility or partial, complete SLDA. That there is effective reduction in MR, and that's another point. Also, sometimes with the anesthesia and the sedation, you tend to have a great improvement in the cath lab. For example, you get trace or mild MR, and then the next day when you do the transthoracic, you get mild to moderate or moderate MR. So very important to have a follow-up echo next day.
So Nicole, what is your antithrombotic management afterward? Like, I know there's no much sufficient data to support a specific protocol, but what is your go-to?
Absolutely. This is a place of no data, as you say. Luckily, this patient is on under rivaroxaban for AFib, so the question is answered, and this is what happens in most of those cases. They already have AFib, and they already have some kind of anticoagulant. Now, if they don't have anything, I tend to put at least if they can tolerate, tend to put an anticoagulation for 1 to 3 months. According on the bleeding risk, but I tend to put something initially. But this is completely homemade recipe. We don't have real data on that.
Because most of the cardiomyopathies already, they have a reason or another for anticoagulation. Nevertheless, if they're not, which is the 10 or 20%, you will go for some sort of DAPT, for example. What about you, Ali? Let's say he's not AF. Any specific management? Will you take the gradient in consideration? Like if the gradient is 6 or 7 the next day, will you go more aggressive with the antithrombotic management? or you'll be the same?
So I think this is a very evidence-free area, so I agree. I don't really think there is enough clarity, but I usually just go with a short duration of anticoagulation or even antiplatelet therapy would be my approach. I try to minimize the duration of anticoagulation if I think the patient would benefit. For example, multiple clips or higher gradient. I think it's not unreasonable to start with a short period of anticoagulation followed by antiplatelet. Otherwise, it seems that antiplatelet therapy is sufficient in this case.
So, Dr. Raed, again, we're talking about life management. 2 years later, the patient came with severe mitral stenosis now, with the fibrosis and reduction, but in a stable, semi-stable condition with an EF of 30. What are you going to do this time?
I think if the AF is still good, and I think he's young, I think probably he deserves mitral valve replacement.
So
I would take him for surgery. Would probably, I mean, I will definitely have the LVAD, the heart failure team, look at him and see if, I think we'll replace the valve, and if he has issue, at least we have a backup of LVAD support for him.
can we do TMVR, Ali, in these cases in the future? Like, there have been lots of talk about, clip or cut these clips and then put a valve. Providing that the LV will tolerate, of course.
So I think we tried it in the tricuspid position where we jailed a pacemaker lead or a failed tri-clip with different platforms. But I think really depends on the platform and the anchoring mechanism of the platform. It might be more complex. I'm not aware of any TMVR in a failed mitral clip as of yet. There is only one dedicated TMVR device that received CE mark approval. That's the SM3 valve. But those patients were treated for mitral valve native pathology, not failed mitral clip or not even MAC. I believe there is a sub-cohort who had SM3 for MAC, which will be presented at some point in the future.
So keep going, Meshari, please. We're
Sure.
closing up in the last 1 minute.
So, in the OBD follow-up, patient did well. He reported, or his echo reported improvement in ejection fraction to 35/40. And the good thing was the patient reported no ER visit since the clip was deployed and since he was optimized, which signified that the results was optimal. Thank you.
Thank you.